Dr. Gaurav is heading the department of Ram Manohar Lohia Hospital at Lucknow, one of the very premier institutions in India. He has done his fellowship in abdominal and cancer imaging from Canada and in neuroradiology from Wisconsin University in the United States. His areas of interest are, of course, in oncoradiology and MRI. He has innumerable publications and presentations. Over to you, Doctor.
Thank you so much. So today we are talking of cystic neoplasms of pancreas. Now, it is very important to understand how a cystic pancreas neoplasm looks, because you do not want to label a pseudopancreatic cyst not a neoplastic if it is so. So the common ones which we see in day-to-day practice is the serous cystic neoplasm, the mucinous cystic neoplasm, the IPMN, side branch and main branch, and of course the pseudocyst. I'll only talk about the common ones. So, of course, they can be divided into macro and microcystic, but the features are overlapping. So let us see few cases. I'll talk less of theory and show you more cases. What do you need to know as a radiologist? First, is a lesion cystic? That's pretty easy. Does it have specific imaging findings? Does it have septa? Does it have soft tissue? Is it enhancing? What should I do? How do I come to a conclusion? And how do I survey it, whether it's benign or malignant? Right. Now, the second question is CT versus MRI. So CT is the workhorse of, day-to-day. In Western countries, the literature says MRI is better, spatial resolution, temporal resolution. You should be doing all cases on MRI, but that's not possible. For countries like ours, mostly we do a CT scan, and MRI is reserved as a problem-solving tool. However, there are certain situations for which MRI is the investigation of choice. As I show you cases, I shall point them out. Right. So what is an MRI protocol? If we use an MRI, it is nothing. It is very similar to any abdominal case which you do on MRI. You take the similar sequences. You, of course, do an MRCP. You take thin, slices. You may or may not use post-contrast images. Now, look at this lesion here. Now, this lesion, when you see on a CT scan, okay, it is cystic, maybe soft tissue. But when you see on an MRI, you see a central scar which you could not see on a CT scan. Now, this clinches a diagnosis. So, at times, MRI can be really contributory. Now, the most important differential diagnosis is pancreatic pseudocyst. So, naturally, whenever we see a cystic lesion in or around pancreas, the first thing which hits to our mind is a pancreatic pseudocyst, and that's normal. However, before making a diagnosis of pancreatic pseudocyst, do not forget to get a good history. Did the patient have a history of acute pancreatitis? Did he have an acute episode of pain? Was his lipase amylase increased? Did he have a trauma? Something like that. If nothing, and still you are seeing a lesion like this, think that it might not be a pseudocyst, it might be something else. Then there can be what is known as non-neoplastic pancreatic cyst, just simple cyst. Now, simple cyst in what is known as true epithelial cysts are not very common in pancreas. They can be found in two disease associations, that is von Hippel-Lindau disease and in autosomal polycystic kidney disease. So these are very simple cysts without any septa, without any soft tissue, and usually they are multiple, numerous, and other organs will also have them. Now, this is a very classical drawing we all have, been studying through our residency, how we distribute the cystic lesions. So the daughter is for solid or pseudopapillary cyst, mother, mucinous cyst, most common age group, and grandma is serous cystic. Coming to the most common, the serous cystic neoplasm. How do you identify? So these are multilobulated. They are almost like, a bunch of grapes, right? So this is how it looks on a CT scan. Honeycomb appearance, right? So these occur in the grandma age, and these are usually benign. So if a patient has a comorbidity, a patient is very sick, she has COPD, you cannot go in for an operation, it's okay to follow it up because these are benign lesions. Right, so again, next CT scan, you can see a lesion, you can see a central scar, very well seen on an MRI. That's a specimen, pathological specimen of the same patient. One more case. Now look at this case. You can see a hypodense lesion on the CT scan. You can see a central calcification scar, but on MRI, the thing is T2 hyperintense. So you're very sure that this is a fluid, this is not a soft tissue. One more case, very, very diagnostic, honeycomb appearance. So what I want to hammer in your head is when you see this kind of honeycomb appearance, multicystic grape-like cluster with a central calcification or a scar, you can very confidently say that it is a serous cystic neoplasm. You do not need an FNAC, you do not need a biopsy. Also remember, cystic lesions are very difficult to biopsy, and FNAC also can be challenging. And sometimes they can be difficult to differentiate from side branch IPMNs. One more case of pancreatic serous cystic adenoma in the tail of the pancreas, small internal cystic spaces, very characteristic. Few more examples of serous cystic neoplasm, central scar, all of them. More examples, all of them again honeycombing, central scar, central calcifications. So we are done with the serous cystic neoplasm. Coming to the second most common, that is the mucinous cystic neoplasm. Now these are pre-malignant conditions, these are not benign, so you cannot leave them. You have to diagnose these because these have a high chance of converting into full-fledged carcinoma, pancreatic carcinomas. So these are in your mother age group, typically 40 to 50 age group. So that is how a mucinous cystic neoplasm of pancreas would look. First thing is usually they are large at presentation. Second, they will not have a cluster of grape appearance. They will be usually one large ball of mucin, and then you will have these multiple cystic, inside. They can have calcification, but that calcification will be peripheral. It will never be central. More examples, again, a large cystic lesion, right? And then you can see a peripheral calcification. Sometimes it can be difficult to differentiate. More example, what do we have here? Mucinous cystic neoplasm. But here what you see is an enhancing mural nodule. The moment you see an enhancing mural nodule, you know that this is a frankly malignant lesion, or in future will turn out to be a frankly malignant lesion. So these cases will go in for resection. Another case, you've got multiple septa, but you also have mural nodularity, very, very bad prognosis. And these turn out to be high-grade pancreatic carcinomas. More examples, this time on MRI. That was a 30-year-old female with a history of biliary pancreatitis and cholecystectomy, and it was incidentally discovered. Remember, lot of these lesions are incidentally discovered. The patient comes in for some kind of abdominal pain. You think it's cholecystitis, cholelithiasis, and actually these are silent tumors, and at presentation they are quite large. So again, you can see multiple septations, right? One very important thing is when you do an MRI, you have to see if there is a connection to the pancreatic duct, especially on your MRCP images, because the moment there is a connection to the pancreatic duct, then it becomes an IPMN, and then no more it is a serous or a mucinous cystic adenoma. Right. More cases, ball of mucinous cyst, right, with peripheral calcification, very, very typical. Similarly, same case seen on MRI. So you can see CT is as good as MRI in simple cases. Now, coming to the third part, or the third important diagnosis which you come in day-to-day practice is IPMN, which are nothing, which are again blobs of cyst, which may be of three types. They can be main duct IPMN, they can be side branch IPMN, and they can be mixed. Now, to call something IPMN, the first thing is you need to show a connection with the duct. If it's connected to the main duct, it's a main duct IPMN. If it's connected to one of the accessory ducts, it's a side branch IPMN. Now, here is where the role of MRI comes. You cannot make this diagnosis on a CT scan. And even sometimes on MRCP, it can be very typical to show this kind of communication. Examples of a main duct IPMN. So whenever you will have a main duct IPMN, remember the main duct will also always be dilated, and it has a very bad prognosis. These will convert into full-fledged carcinoma. So if you get a fully dilated main pancreatic duct, something like this, along with this kind of cyst communicating, you know that this is a main duct IPMN with a large malignant potential. You raise a red flag. Then you have what is known as branch duct IPMN, which are again a cluster, and this cluster is very similar to the cluster of grapes we just now saw. However, these will also show communication with the main duct or the accessory ducts. That was a simple case of a cyst seen on ultrasound. Then it was taken on CT scan. Again, could not understand what this cyst was. We did an MRCP, and you can see how well this cluster of grapes shows the communication with the pancreatic duct. So this was diagnosed as a branch duct IPMN. It was followed up and it did not turn malignant. Few more cases of IPMN. So you can have these kinds of mixed, IPMN, where there will be multiple clusters of IPMN, both main branch and side branch, full of IPMN. See multiple small cysts connected all over, right? And sometimes these cysts can have soft tissue around them. The moment you have soft tissue inside them or around them, again they are turning out to be malignant. One more example. There, you can see a IPMN, but what you have inside is an enhancing soft tissue. Again, the moment you see an enhancing soft tissue, you know this is a malignant lesion and this should go for surgery. So what are the signs of malignancy? If your main pancreatic duct becomes more than 8 mm, if there is a solid nodule in the duct, or if the dilatation is increasing very rapidly, these are the sinister signs. So this was an example of a side branch IPMN where, as you can see, there was a small cystic lesion. It was followed up. It started becoming bigger and bigger with some soft tissue component, and it turned out to be fully malignant, and it was removed. So there is a big, follow criteria for IPMN. What you need to remember is that in case the main pancreatic duct is more than 8 mm, or it is a very rapid growth, you need to resect it. If it is suspicious, that means, the main pancreatic duct is between 5 to 9 mm, and the cysts are increasing, you need to follow it. How you follow it up? Either by endoscopic ultrasound or by MRI in every 6 months. Right, now let's talk about some uncommon neoplasm. Okay, I've got 3 minutes. Uncommon neoplasms with specific finding. One is SPEN, or solid pseudopapillary neoplasm. So this is a neoplasm found in young females, 20 to 30 years. And though the Western literature says it's very rare, but to my experience, it is not that rare. And in our countries, it does happen once in a while. So if you have a young female coming into your, OPD or IPD and is referred for a CT scan, and if you see this kind of dirty picture, by dirty picture, I mean a big cyst with a lot of soft tissue component, most probably you are looking at solid pseudopapillary neoplasm, or what we call as SPEN. Very characteristic, images. Again, the same on CT scan, dirty looking, large cyst with areas of hemorrhage in it. Young female, most probably you are looking at SPEN. What do we have here? Neuroendocrine tumor. So pancreas does harbor neuroendocrine tumors, and these have a very characteristic pattern, and that is that they are very, very vascular. Because of this vascularity, you can actually pick them up. So what will happen is, because of the vascularity, they are going to enhance very beautifully on the arterial phase, and since they are so vascular, they will have central necrosis. So this kind of ring enhancement is very characteristic, and of course their metastasis, which is very, very common in neuroendocrine tumors, would be hyper intense on T2. How would be it on CT scan? It would show good enhancement, peripheral strong enhancement of neuroendocrine tumor. Okay, let's conclude. So what did we see? We saw 4 very important entities. First, we saw the serous one, which was a cluster of grape appearance, which is the grandma lesions. These will have a central scar or a central calcification. These are usually benign. Then we saw mucinous, which would be a big cyst with a peripheral calcification, usually in the age of mother, 40 to 50. These can turn malignant. Then we saw main duct IPMN, which is dilatation of the main pancreatic duct. We saw side branch IPMN, which are again cluster of grapes, but with a connection to the pancreatic duct. Thank you so much. Questions, you guys can take it in the tea. I think we don't have time, right?
We still have time, sir. Thank you, sir.
We have time? Oh, I'm 2 seconds, yeah.
Thank you,
Fine.
sir. I think we should take questions for you, sir.
Okay. So if you have any questions, I'm, more than happy to take it. Yeah, please.
If there are no questions from the audience, I have one question, sir.
Yeah, sure.
I'm a surgeon, and we frequently have this diagnostic dilemma of diagnosing cystic neoplasm of pancreas. And we are often said that even MRI with MRCP can give adequate information in comparison to CT. So what is your suggestion regarding the first modality of diagnostic modality, imaging modality?
See, ideally it should be MRI, but then Depends where you are. If you are in a private practice where the patient can afford, it's good. Please send him or her to an MRI. But in day-to-day practice, it becomes difficult to get an MRI done, and we rely more on CT scan. I would rather, put in a needle. I am more confident in putting in a needle, and take out the sample and tell the surgeon directly that what the lesion is. That is one thing. We usually keep MR reserved to see communication with the duct. That is the question the surgeon usually asks, is whether it's communicating and for follow-ups, where we don't need to give contrast, where we can do the follow-ups.
Thank you, sir.
Right? Thank you.
Thank you for making this complex topic very simple, sir.
Thank you so much.
It's quite an informative topic.